In July 2026, Medicare made a proposal. They want to cut what they pay surgeons for hip and knee replacements by 20%. If approved, this would take effect January 2027. And here's what's at stake if that happens. More Medicare patients will struggle to get the hip and knee surgeries they need. You may be asking yourself, why would a pay cut to surgeons matter to me? Surgeons get paid really well. And you're right. We're fortunate to have jobs that are both well paid and fulfilling. And that's something we should never lose sight of. But I felt I had to make this video because 2 out of every 3 hip and knee replacement patients in the United States rely on Medicare. That means these cuts could affect millions of patients across the country that need a joint replacement, and even affect those who have a joint replacement in them right now. But most people have no idea this is happening. Medicare is accepting your comments on the proposal until September 14th, 2026, about 3 weeks after this video goes live. So before that window closes, I'll walk you through things that most people are never told, including what Medicare pays orthopedic surgeons like me, why the cuts aren't even aimed at what actually makes these surgeries expensive, and what this means for anyone who needs or already has a joint replacement. Medicare currently pays surgeons about $1,161 to perform a hip or a knee replacement. The current proposal would bring that amount down to about $928. To give you some context, the payment for these operations has already fallen about 20% over the past 6 years. This proposal would drop the payment by that percentage in a single year. And when you adjust for inflation, the payment is already less than half of what it was in the early 2000s, even before we consider the new proposal. Now, I'll break down what these numbers mean over the next couple minutes, and then I'll explain how these cuts affect you. With what you know so far, you might assume that these cuts are meant to reduce waste and save Medicare money. But the thing is, even with these cuts, expenses are going up. For a typical joint replacement performed in a hospital, the hospital receives about $13,116, or 92%, of the total Medicare payment. The surgeon's payment of $1,161 is about 8%. So to begin with, the surgeon payment is a small fraction of the overall Medicare expense. But the same set of proposals for 2027 actually increases the payment to the hospital by 11.5%, to about $14,628. And again, the surgeon payment drops to $928. Not only is the smaller share being cut, but the larger share is going up. That means that the total Medicare pays to the surgeon and the hospital goes up overall from about $14,277 to about $15,556, a roughly $1,300 increase. Controlling Medicare spending is important, and I don't think anyone would argue otherwise. But as you can see, these cuts don't add up to money saved on these surgeries. And if anything, the cost per surgery is going up. Let's back up for 1 second. Why are these cuts happening in the first place? A large part of Medicare's reasoning is that surgeons and their clinic staff need less time and work to provide joint replacement care these days. One example that they use is that most patients stay in the hospital much shorter than they used to, so surgeons don't have to provide as many hospital visits these days. And that's true, we don't. But what the reasoning doesn't account for is that the work didn't disappear. It just moved somewhere else. Compared to before, modern joint replacement care involves much more work before patients ever reach the operating room, like optimizing medical conditions, educating patients, coordinating the recovery plan, and communicating by phone and electronic messages. And after surgery, a lot of the follow-up that used to happen during the several days in the hospital now happens through phone calls, messages, photographs, and other outpatient care. That shift is actually a big reason why shorter hospital stays are possible in the first place. And all of this is important because Medicare isn't just paying surgeons for the hour or two spent in the operating room. The payment is intended to cover the operation itself, plus the care surrounding it, including planning and coordination beforehand and follow-up for 90 days after surgery. But much of that work doesn't show up if we're just counting how many hospital visits the surgeon performs. So if these cuts go through, what does it actually mean for patients? I'll start with what it means if you need a joint replacement, and then I'll get to what it means if you already have one. There are 3 main ways that I think this could directly affect you if you need a joint replacement. The first is that you may have fewer surgeons to choose from, and longer waits for surgery. These cuts could push some practices to limit how many Medicare patients they see, or in some cases, stop accepting Medicare altogether. And the reason is simple. Delivering medical care has real costs. In many private orthopedic practices, roughly half of the revenue goes toward overhead. For example, staff, rent, and medical record systems don't suddenly get 20% cheaper when Medicare cuts reimbursement by 20%. So a 20% cut can translate into a larger percentage reduction in what remains after those expenses are covered. At some point, that can make treating Medicare patients financially difficult to sustain. But older surgeons may have another option, and that's earlier retirement. About 1/3 of American orthopedic surgeons are already over 60, and worsening economics could give older surgeons another reason to retire sooner. At the same time, the country's population is aging, and as I'll get to in a moment, more and more people are needing hip and knee replacements. So if the available surgeon workforce shrinks while the demand for surgery keeps growing, there will be fewer surgeons to choose from when you need your surgery. And fewer surgeons also means longer waits, both for an appointment and for the surgery itself. But even when you get an appointment, the second effect is that you may get less time and attention from the surgeon and their team, because surgeons will be pressured to fit more patients into the same hours. The number of Medicare hip and knee replacements performed in this country has more than doubled over the past 2 decades, even as inflation-adjusted physician payment for these operations has fallen. Surgeons have been able to absorb the cuts by working more. Some of that growth has been made possible by real improvements in efficiency, but those efficiencies have their limits. At some point, more cuts creates pressure to see more patients in clinic or perform more surgeries within the same number of hours, and you can only compress that time so far before each patient starts getting less of it. Fitting as many patients into the same amount of time doesn't make anyone happy, and it probably isn't good medicine. And once you've decided on surgery, the third effect is that you may have to travel farther for it, with fewer options on where to have it done. When the surgeon payment goes down and the hospital payment goes up, one option for surgeons is to become employed by a hospital or health system. And this has already increasingly been happening. During the cuts over the last several years, surveys show that the percentage of hip and knee surgeons employed by hospitals went from about 7% in 2009 to over 31% in 2025. There isn't anything inherently wrong with hospital employment, but as more physicians and practices become part of larger health systems, more surgeries become concentrated within those health systems, and away from independent surgery centers where many of those surgeries happen today. That means that the hospital where you need to have your surgery done may be farther from you than the surgery center that would have otherwise been a more convenient option. Some patients will likely need to travel much farther just to get the care they need. So that's how the cuts could affect you if you need a joint replacement. But even if you already have one, you can still be directly affected by all this. The implant in your leg is a mechanical part, and mechanical parts don't always last the rest of a patient's life. For example, the implants can loosen or get infected. And when that happens, the operation to change the implants is called a revision surgery. The chance of needing a revision is about 5% for patients in their 70s. But for patients in their 50s, the risk is as high as 35%, because they're more active and they have more life ahead of them after surgery. So there's more opportunity for something to go wrong with the implant. The thing is, a revision surgery isn't just doing your surgery a second time. It's often much more complex than the first one, and it requires a different set of skills in your surgeon. And that's why, although a fair number of surgeons do first-time hip and knee replacements, far fewer do revision hip and knee replacements. But what's concerning is that there are already signs that there are fewer surgeons available to perform revision surgeries on Medicare patients. Between 2013 and 2019, the number of high-volume revision hip surgeons treating Medicare patients fell by more than 36%. And the number of counties with at least one high-volume hip surgeon fell by more than 30%. All of this means that if you have a joint replacement, finding a surgeon with the skills to fix its problems may continue to get harder. So why is this happening with revision surgeries too? Just like with standard hip and knee replacements, inflation-adjusted payments to surgeons for revision hip and knee replacements have fallen about 50% in the last 25 years. And revision surgeries often require more preoperative planning, take longer in the operating room, and involve much more complicated postoperative care than routine joint replacements, which makes the payment decline even harder for practices to absorb. The bottom line is that these factors are making treating Medicare patients less and less sustainable, and Medicare patients may have a harder time finding a surgeon to do the first-time and revision joint replacements they need. But let's move past the money and look at the big picture here. All of this comes down to something that's bigger than payment formulas and practice economics, and that's the value of our mobility. What I mean is, how often do we go to the doctor and we're told we need to be more active? It's like someone who smokes being told they need to stop smoking. They know they need to stop smoking. They've been told a million times. Being told to be more active is the same exact thing. We all inherently know that being active is good for us. But then, why is it that we are devaluing two of the most powerful interventions that we have that treat a disease that stops us from being active. Being active is more than just a luxury that allows us to go out and do fun things. It's a health marker. Just like our blood pressure and our blood sugar, our activity levels tell us about how we're living. And yet, as human beings, it's natural that we often take for granted what we have until we don't have it anymore. Our mobility, our ability to stand, walk, play with our children and grandchildren, is a prime example of that. When we lose our mobility, those things we took for granted every day suddenly become a luxury that we would give anything to have again. I hope that our access to hip and knee replacements doesn't follow in that same vein. Because if we don't recognize and value what that access means for us as a society right now, then we may wake up one day and realize we don't have it anymore. And people all over this country will suffer as a result. Now, there is something that all of us can do about this. Medicare is accepting written public comments on the proposal until September 14th, 2026. Comments become part of the official public record that Medicare has to review before making a decision. And comments specifically from patients who depend on Medicare have the potential to be the most meaningful and impactful. I'll put the link to comment on the screen and in a pinned comment below. If this is an important issue to you, leave Medicare a comment on what this surgery has done for you, or what it would mean if you or a family member couldn't get the care that you need. It takes just a few minutes, and it's the most direct way to have your voice heard. A final decision is expected around November 1st, 2026, and whatever is in that decision takes effect January 2027. If you know someone that this affects, please share this video with them. And clicking the like button helps other people find it too. Stay involved, stay informed, and stay well. I'll see you in the next video.